I'm Curtis Stinnes from Scripps Clinic, and I'm joined by three esteemed colleagues tonight, Dr. Jim Hermiller, Dr. Patricia Pellica, and Dr. Philippe Pibereau. And the discussion tonight is really surrounding TAVR hemodynamics, specifically looking at echo hemodynamics as well as catheter-based hemodynamics. And as many of you are aware, there's been some increasing discussions on the podium recently about a discordance that we're seeing between echocardiographic gradients and invasively measured gradients. And this may have implications for patient safety. Some patients are being sent back potentially for repeat interventions, which may or may not be necessary, and also has implications for how do we follow these patients and what do these numbers mean. So that's what we're going to be discussing tonight. There was a recent video presentation with Dr. Michael Mack, Dr. Abbas, Dr. Wood, and Dr. Grayburn, and Dr. Leon, which actually discussed these topics in great detail. And we're going to be commenting on those videos, and further discussion will be had in those regards. And let's go ahead and start watching the video.
We'll start directly into the case with a 65-year-old male patient with a history of aortic valve replacement 10 years ago with a 21mm trifecta valve. Came presenting with functional class 3 symptoms and a TEE demonstrating severe aortic valve regurgitation. Immediately post-implant, the patient generated an echocardiographic gradient of 24mm of mercury after receiving a 23mm SAPIEN S3 valve. The discharge echocardiogram demonstrated a gradient of 31mm of mercury. And obviously, when we see these numbers, by definition, this indicates a non-procedural success due to the elevated echocardiographic gradients. At our institution, we always do simultaneous immediate post and pre-implant echo and cath gradient. And if we look at this gradient of 24mm of mercury generated by echocardiography, we notice that at the same time, the invasive gradient is only 10mm of mercury. Now, interestingly enough, the prior implant echocardiogram in the degenerated trifecta valve also generated an elevated gradient of 43mm of mercury, but a simultaneous invasive gradient demonstrated a gradient of 22mm of mercury, suggesting again this discordance between echo and cath, not only in the post-TAVR implant, but also in the degenerated surgical aortic valve replacement. It was really this case that brought my attention several years ago, where we had an implant of a 20mm S3 valve demonstrating an echocardiographic gradient of 40mm of mercury with an invasive gradient of 11mm of mercury. We collected 8 cases, 4 post-TAVR and post-valve-in-valve TAVR, and published in the Journal of Structural Heart. And then we demonstrated our experience in this paper with over close to 300 patients, native and valve-in-valve, again demonstrating that this discordance occurs both in the native valve as well as in the valve-in-valve post-TAVR, to a larger degree in the valve-in-valve population. This happens due to reasons that Dr. Grayburn will allude to for several reasons. But more interestingly, what we also noted is this change between the post-TAVR as well as the discharge echocardiographic gradients. This change between post-TAVR immediate under sedation and the discharge gradient is related to the no sedation during the discharge echocardiogram, improvement in the transvalvular flow, better patient position and Doppler angle, as well as improvement in the blood pressure control. We all notice after we implant our valves, the blood pressure is elevated, and the following day, the blood pressure and the SVR all settle down, giving us a higher gradient compared to the immediate post-implant. Thank you very much.
So I'm going to show you 2 cases, 3 months out to 6 years post-THV, my disclosures. So as we all know, echo is routinely performed to monitor valve function, and VARC3 highlights the need for comprehensive assessment with multiple metrics. But in the real world, many clinicians use symptom status and changes in mean bioprosthetic gradient on echo to guide clinical practice. And we know patients have been brought back for either redilation or sometimes even valve-in-valve because of elevated gradients on echo. 2 representative cases in Vancouver. 57-year-old gentleman, TAVI in 2017, significant symptomatic improvement, but remains NYHA2 with morbid obesity and a BMI greater than 45. We did a CT with Jonathan and Philip showing no valve thrombosis, no halt. And the question was possible early valve deterioration. And you can see the gradient 16, 9, 28, 27 over the last 3 years. We brought him in, Short procedure, no contrast, 5 to 10 minutes, invasive hemodynamics, and generated a gradient of 18. We thus reclassified him as normal function with ongoing follow-up, noting the discordance between echo and invasive gradients. A second recent case, 82, valve-in-valve TAVR with a 20 millimeter SAPIEN 3 and a trifecta, significant improvement, but remains NYHA2, comorbidity of significant COPD. Again, a CT showing normal leaflets, and here the gradient has gone from 17 to 46 on follow-up echo. Invasive hemodynamics, mean gradient is 19, normal leaflets, significant improvement after her procedure a year ago, reclassified to normal function. We feel this is such an important phenomenon that we got together, and this is all available on clinicaltrials.gov, for the complete TAVR trial that we're now enrolling in, 4,000 patients, 2,000 complete revas staged, 2,000 medical therapy, median follow-up 3.5 years, that we've added invasive hemodynamics both at baseline with an on-table echo, and then in follow-up for any patient with a gradient over 20. A second project we're calling Disrupt TAVR. We've now enrolled 12 patients. This would be looking at your list, any patients that are symptomatic with a mean gradient either greater than 20 or 30. We do a CT, no evidence of valve thrombosis. We bring them back for invasive hemodynamics, 6 steps, 8 tracings, takes just under 4 minutes, no contrast, 50 patients, 6 centers. And I think the early results are fascinating. 12 patients have been performed, reclassification of THV valve function using a mean of greater than 20 or 30. Again, not the full VARC definition, just the mean gradient portion. And 10 out of the 12 patients would be reclassified based on the invasive hemodynamics.
So those were very interesting discussions and presentations there about those patient scenarios. I'm curious, so Jim, in your practice, do you see patients like this?
Yeah, I think these were great examples of cases we get calls on every day. I'm sure you do. They're going home discharged and they have a high gradient based on a high velocity or at 30 days. And what do? And there's really no understanding, I think, out there that these echo measurements, these derived gradients that we take, I think they're often taken as the golden standard, and there is not an understanding, not really a recognition that there's this discordance between what really counts, the hemodynamic gradient, and what echo is coming up with.
Yeah. So this brings up a very good discussion point, and I want to make the point that echo is quite reliable for native aortic stenosis, right? And so we're sort of not questioning that, but it's more of the bioprosthetic valves that we're seeing this discrepancy. I know that in my practice, I think a lot of these, a lot of the discussion surrounding this discrepancy has brought my attention to the hemodynamics. And in my practice, I've been routinely measuring an invasive gradient at the conclusion of the TAVR procedure. And I find that to be very useful. Jim, are you doing that in your practice?
Yeah, so I've moved more and more towards that. It used to be just sort of valve and valves. Then it was 23s and 20s, and now it's becoming everyone. And I think it should be a common practice because, I think the studies that Abbas showed, these were simultaneous hemodynamic measurements and echocardiograms. And despite great technique, the echocardiogram, overestimates the gradient and underestimates the valve area in, a number of these patients. So it's important to do that. Now you've got a baseline. Now you can trust what you got when they're discharged and then in follow-up.
Yeah. And, it's not uncommon that I get a phone call from a referring physician, discussing a patient that may have had a TAVR 3, 4, 5 months ago, and the gradients appear elevated. And they call me and say, well, something's wrong with the valve. I'm concerned about this. And this leads to a lot of interesting discussion and debate sometimes. So hopefully we're going to get more to the bottom of this. I'm impressed with David Wood's passion for this and the fact that we have 2 trials being done. I think we're going to glean some very interesting information from that. So I guess the big question now is, why do we have this discrepancy? So let's go ahead and watch Dr. Grayburn's presentation to get some more information about that.
So this is old stuff in a way. Back in the 1960s, John Tobin, Sabu Rahimtullah, Jeremy Swan wrote this paper in Circulation that talked about stroke work loss of the LV. So it turns out this LV sees the recovered pressure. So the aortic valve area using the energy loss index formula can be used rather than the continuity equation to correct for this. But most people don't do that. We also have this issue with the modified Bernoulli equation, so that the pressure drop is equal to half the density of blood times the velocity squared at the vena contracta minus the velocity squared proximal, plus a component of flow acceleration and viscous friction, which are generally ignored and condensed down to 4v squared, which we all accept and use every day. But V1 cannot always be ignored. So if the LVOT velocity is increased, you can't ignore it, and it'll overestimate the calculated gradient from the velocity. Here are some examples where you can't ignore it. And then it's also important to think of spatial distribution of velocity across a vessel. So here's the aorta in pink. The LV would be to the left. As flow enters the aorta, it is in a flat profile. If one were to try to get away from the limitation of continuous Doppler and measure Doppler just in this box using pulse Doppler, it wouldn't matter where the box is, because the velocities are equal across this area. But as flow gets down the aorta, it becomes parabolic. It's higher in the middle and lower, even zero at the edges. If you put pulse Doppler here to measure recovered pressure, you'll be measuring the centerline velocity. In other words, you'll still overestimate, because the mean velocity across here is not the one in the center, it's the mean of all of these velocities. So parabolic flow creates problems for Doppler too. Now, just a reminder, we all know that the transvalvular gradient is flow dependent, and Dr. Abbas has already talked about that. So these are flows or gradients at different valve areas for normal flow, but at low flow, the gradient will be low at all of these, and Doppler will be less likely to overestimate here. Going back to Ajit Yoganathan's paper in 1988, I would encourage everyone to read this. It's important reading for fellows. It's a review of hydrodynamic principles. And importantly, in the middle of the article, he says, when does the simplified Bernoulli equation not work? One of those answers is prosthetic heart valves. It doesn't work in prosthetic heart valves. And again, this is knowledge that sort of is fundamentally derived from hemodynamic principles. So what do we do about it? Well, here are the guidelines for using echo to assess prosthetic valves. These are pre-TAVR guidelines. And I just want to focus on this point right here, that normally in aortic stenosis, you have a very parabolic profile of the Doppler, but here it's triangular with a short acceleration time. How many times have you seen acceleration time on an echo report? If it's less than 100, that implies normal prosthetic valve function, regardless of your measured gradient. And in this example from Zogby, you have the AVA or the EOA index, and that'll tell you whether you're dealing with a high flow state or patient prosthesis mismatch. I would suggest that these be modified a little bit so that now we use the energy loss index. We use the VARCS-3 criteria instead of peak velocity. Use the energy loss index to calculate area. And then we consider that another alternative to high flow or patient prosthesis mismatch is pressure recovery. So to summarize, Doppler measures maximal velocity at the orifice, not downstream. Conversion of velocity to mean gradient has known errors. The velocity and gradient are flow dependent. So the ambulatory TAVR patient 1 month after may have higher flow than the echo done on the table or at discharge. And consider using the energy loss index formula for aortic valve area, and pay attention to acceleration time and Doppler velocity index, although those need to be validated. Thank you very much.
Well, thank you, Paul, for that very clear explanation as to why there may be a discordance between invasively measured gradients and echo gradients. How do we put everything that we have just heard from Amr, David, and Paul into clinical practice? Marty, you're on.
Mike, thank you very much. During TAVR procedures, there's no question that echo has many important, valuable functions. We think it frankly improves the TAVR strategy, helps us with valve sizing, helps us with certain subtleties of how we implant these valves and how we position these valves. Certainly, it helps us to diagnose and determine the severity of paravalvular regurgitation. We think it's important to diagnose and manage complications. if you perforate a chamber, if you suddenly have hypotension and you have to diagnose coronary obstruction, looking at LV function, many different ways we use it. But it also has some very specific limitations. And the major limitation is in determining the absolute reduction in transvalvular aortic gradients due to this varying discordance between echo and cath-derived hemodynamics of newly deployed and normally functioning TAVR valves. This is from that same data set, and I think you can see for both self-expanding and balloon expandable valves in the cath lab during TAVR procedures immediately after the implantation of the valve, there is discordance consistently with echo overestimation of the intraprocedural aortic valve mean gradients for both of these kinds of valves, although you will see more of a variance in the balloon expandable valves. If we take it one step further and look at large versus small valves, you'll see that there is more of a discordance in small valves, particularly small balloon expandable valves, between the invasive cath and echo-derived gradients. So keep this in mind. Small valves, balloon expandable, there is more of an echo discordance consistently. There's also, and it's been pointed out, that varying flow states and varying volume status and other things can affect the measurement of these gradients by our current echo techniques. So if you compare the post-TAVR versus the discharge echoes, you will consistently see in both self-expanding and balloon expandable devices for both small and large that there's always a discordance or difference between the post-TAVR versus the discharge echoes, with the discharge echoes being higher. And that's accentuated, again, in small balloon expandable valves. And a final concept that Paul alluded to is this issue of echo velocity and flow patterns. Clearly, laminar flow results in high velocity, which is usually seen in an efficient valve design. Turbulent flow results in lower velocity, which is more commonly seen in less efficient valve designs. So there are issues relating to the technique of how you obtain the Doppler signal, as Paul has commented upon, and there are also some valve design specific features that affect flow patterns. So these are two pulsatile flow patterns at peak systole in smaller valves. And I think you can see that the flow patterns are quite different. On the left, more laminar; on the right, more turbulent. So because laminar flow maintains velocity, the echo overestimates the pressure gradient in a valve with laminar flow compared to a valve with more turbulent flow. And this perversely rewards, from the standpoint of gradients, valve designs with turbulent flow.
So that was a really fascinating and interesting discussion there. I think it brought up some really interesting topics. I know in my practice, I've definitely seen this phenomenon. We are definitely finding that there is an overestimation of the gradient in many of these patients post-TAVR, and we're not seeing that with the invasive gradient. And so it's really fascinating to know that even back in 1988, there was already a knowledge of this phenomenon with bioprosthetic valves. So, there are different valve designs, of course, and these different valve designs are associated with different flow patterns. Some have more turbulence, some may concentrate the flow more in a laminar flow pattern. And that may explain some of the differences that we see in these valves by echocardiography. And I think we see less of those invasively due to the pressure recovery phenomenon that we're measuring there. But, it's a common discussion point where people say, well, the patients that have the smaller valves seem to have really high gradients. Should I be concerned about that? Is this representative of a true sort of PPM or patient prosthesis mismatch situation, or is it just a factor of concentration of the velocities? Philippe, what are your thoughts on that?
Well, what we use to measure the gradient, to calculate the gradient by echo, is the Bernoulli formula. But what we do to the Bernoulli formula for the clinical use is brutal. In the original Bernoulli formula, you have 8 terms, and finally we end up with just 1. So it's an ultra simplification. We neglect the viscous friction component, the flow acceleration, and we only have the convective acceleration, and then we neglect the pre-valvular velocity. And also the other main factors for difference between cath and Doppler is the issue of pressure recovery, because the Doppler measure the gradient at the vena contracta, where the pressure loss, the pressure gradient is the worst, whereas the catheter is measuring the pressure a few centimeters downstream in the ascending aorta, so post-pressure recovery. So echo does not take into account pressure recovery, whereas catheter does. And the issue is that if you have, let's say, more stenosis or more turbulent flow, a worse hemodynamic, a worse valve hemodynamic function, well, these factors will have less impact. So the Bernoulli formula will work okay, and there will not be as much pressure recovery. And so catheter and Doppler will be pretty close, right? But if you have a better valve with more laminar flow, with larger airways, with eventually lesser gradients, this is where you have more and more discordance between echo and cath, and that echo is measuring much higher gradient than cath, because less pressure recovery and less applicability of the Bernoulli formula. So that's why, you know, the better is the valve and the more discrepancy you will have. And so it's bad that it's in this direction, because the bad valves are more rewarded by this phenomenon that the good valve.
Well, that's exactly. A really good point.
And just to build on that, the point you raised, Curtis, about the size of the prosthesis, that of course is also important. A smaller orifice prosthesis, a smaller size, is inherently more stenotic and is going to have a higher gradient. And we have normative values for different prosthesis sizes, and that's confirmed by those measurements.
Right. So I want to talk.
It is. I was just going to say, but it is interesting from Amr's data that the discordance is greater between the hemodynamic and echo for these small valves, independent of everything else.
Yeah. No, that's a really good point.
In absolute term, which makes sense, because of course, in absolute term, when you have a smaller valve, you have a high gradient. And so the difference will also be higher in absolute term, but not necessarily in percent terms, you know. Of course, if you go into the larger valve, there is no gradient or not much gradient anyway, regardless of the modality. So that's, you know, a bidirectional phenomenon, let's say.
So Jim, I wanted to ask you, what are your thoughts about high gradients after TAVR versus SAVR, and the concept of patient prosthesis mismatch with TAVR and SAVR, and the clinical outcomes in those situations? Why we see some discrepancy between those with SAVR and TAVR? What are your thoughts?
The hazard ratios are quite different between those two. Yeah, I think out in clinical practice, what happens is a TAVR definition of PPM based on EOA from echocardiography is thought of in terms of its implications like the PPM of a SAVR that's based on, hey, on the benchtop, the projected EOA. And so I think people need to understand that there are very different definitions, and the implications of outcomes are very different.
Another thing to look at is the other features on the echo. Is the left ventricle becoming hypertrophied? Is there diastolic dysfunction that's progressing? Is the RV systolic pressure going up? Those other things are other clues that dysfunction might be occurring. But if all of that is good, then your gradient may be insignificant.
We're going to get into this, and let's go ahead and start watching the video.
So most important from a clinical standpoint is how we follow these patients after TAVR or after surgery. So the echo for TAVR follow-up is used to monitor changes in valve hemodynamics, but you've got to compare it with a baseline. We always look at the presence and severity of paravalvular regurgitation. We also look at LV function, which we think is important. So echo has many uses post-TAVR. What baseline do we use for hemodynamics? Well, it's the discharge or 30-day echo. And it's extremely useful if we can compare that with the cath-derived gradients whenever possible to see to what degree a discordance was observed during the procedure. The absolute value of the echo gradient is less important than serial changes, and always be aware that intra and inter-observer variability with echo-derived gradient measurements can be an issue. We have generally agreed that the echo-derived mean gradient changes of more than 10 millimeters are significant. Patient comes back for follow-up, either early or late, and we see an elevated gradient on the echo. We have certain criteria for describing what we think is either moderate or severe increases in those gradients. If we do think that that gradient increase is relevant, either clinically or hemodynamically, by virtue of being a significant change, it's not unreasonable to do a cardiac CT and to rule out valve leaflet thickening or valve thrombosis, in which case systemic anticoagulation may be indicated. But if not, if the CT is negative, then I think we have to make a decision about how to clinically interpret that elevated gradient. And here's where the issue of concordance and discordance comes to play. And we have to check the echo gradient to be certain that it truly represents a relevant cath-derived hemodynamic invasive gradient, where intervention may or may not be indicated under those circumstances. So final thoughts. We've really been struggling with this new issue and these new terms. So echo discordance is now a term that we have used much more frequently, and it's commonly applied now as we follow patients after TAVR or after bioprosthetic valve surgery. Should always be considered during follow-up when there's an unexpectedly high echo gradient, especially in smaller valves. And we should use this information to make more rational decisions about clinical intervention in our patients. Thank you.
Well, that was a really interesting talk by Marty there, brought up some really interesting points. Patty, what are your thoughts about this? How should we use echo-derived gradients to monitor our patients after having a SAVR or a TAVR procedure?
So for many years, we have recommended doing a pre-dismissal transthoracic echo in patients who have had surgical valve replacement. And that's sort of like the fingerprint for that patient. It's unique to them, and we know that's their baseline, and that is our guide for anything that happens in the future. Now, a little bit different for our TAVR patients is that their hospitalization is so brief. So we have been doing our dismissal, our follow-up first major echo at 30 days at their first follow-up visit instead. Then the patient has normal mobility, and we can evaluate the prosthesis from all the windows, and it's a more comprehensive assessment than what we can do in the rushed environment of the cath lab, where we can't optimally position the patient. And that's their baseline, their fingerprint, and that's what we use. I think it's important also to review the guidelines. The guidelines for valvular heart disease do recommend that the TAVR patients receive an annual echo. That is very appropriate. Interestingly, the guidelines do not say the same for the SAVR patients, but I do think that an annual echo is appropriate for them as well. If you wait until the patient, till years have gone by, you might have missed an opportunity to intervene on a thrombosing valve where you could have caught it early if you had done the assessment with an echo.
So Philippe, how should I handle a situation where I've done a TAVI, which I think is appropriately sized for the patient based on the CT, and we've ostensibly had a great result. And I get called by the echo lab, the next day, and they say, well, your patient has a mean gradient of 24. Is that something to be concerned about? And how should I use that number, if you will? And I know that we shouldn't just use a specific number. I want to get your thoughts on that. But how should I use that information to monitor the patient going forward?
Yeah, so if it's early post-intervention, and it is typical that you will see higher gradient at the pre-discharge echo versus at the time of the procedure because the flow increased, because the hemodynamics changed. So yes, it's not unusual that you're going to get a call from the echocardiographer doing the echo on the patient before discharge and say, hey, well, I have a mean gradient of 24, Valvular is kind of small, and I have a mismatch, and what do I do? Well, again, first, look at the leaflets. If the leaflets have normal leaflet motion, normal morphology, and if you don't see well the leaflet, well, our threshold to do a TE at this time or a CT angio is quite low, just to be sure that, you know, the leaflet are fine. If yes, well, this is prosthesis patient mismatch. There is some high residual gradient that may probably be higher that you would get on CAT, and that will remain stable during follow-up. And then after, and that's why I think the point mentioned by Patricia is very important, to get a good baseline, a good fingerprint echo where you have your baseline values. Whatever they are low or high, it's not that important. And then during follow-up, what you're going to look is not the absolute value of the gradient, say, oh, now it's higher than 20 or 18 or 23 or 24, but more the delta, the changes in gradients, and with concomitant change in that area. When I have an increase in gradient that is 10 millimeters of mercury or more, with a concomitant decrease in AOA and Doppler velocity index, this is a red flag that I may have an hemodynamic deterioration, I may have a dysfunction. Because in a true and stable mismatch, you will have the same gradient at discharge versus at 1 year versus at 5 years. It's going to be stable. If you have a bioprosthetic valve dysfunction, you will see an hemodynamic deterioration. So I think one of the take-home message is, instead of looking at a given value of gradient at a given echo at a given time point, it is more important to look at the changes over time. That's really our red flag. And if there is these changes, then this is where we do more comprehensive imaging and look at the leaflets again.
I think that's a really good point. And I really like the way Patty put it, is the fingerprint of the patient. I've never thought of it that way, but that's a very good way of looking at it. So your point is that when I get these phone calls that the mean gradient is 24, that's not necessarily critically important, but looking at what it does over time is critically important. And a change of more than 10 would raise some flags, especially if the EOA has dropped.
And this is what we insisted in the VARC3 definition of bioprosthetic valve dysfunction. We do not talk about cut point of gradient of valve area, but more of deltas, of changes over time, versus the fingerprint early after intervention.
So I want to talk practicality, clinical practicality. Jim, what do you think of the proposed algorithm that Marty discussed? Let's talk about how we actually manage our patients on a day-to-day basis and how we handle these things. I'm curious about your thoughts.
I think it's a very practical and useful algorithm. I mean, that's sort of the approach that we take. Get a fingerprint. I love that, right? And then see a trend. You see a trend that's going the wrong way. Gradient goes up 10. The valve area is going down. Make sure it's what's going on. Is this a leaflet issue? Best way with CTA, they've got HALT, treat it with anticoagulation. If they don't, and you've got this and you think you need to do something with it, get a gradient before you go ahead and put another valve in there or do another invasive procedure. I think that is a beautiful way, because we saw it in the cases that were discussed. You know, if you found a gradient at the invasive measurement that was found at echo, you're probably going to do a valve and valve or something else. But having the invasive gradient, continue to watch.
Yeah, no, I do the exact same in my practice. I think that, you know, I love the fingerprint term. We do invasive gradients and an echo. You know, I'm much more concerned if there's a catheter-based gradient at the conclusion of a valve and valve procedure or a smaller valve, for example. But I can go to sleep well that night if I know that catheter-based gradient is low, despite what the echocardiogram may show of a mean gradient of 24 or 25. You know, I sleep well at night knowing that the invasive gradient was low. And then I follow those numbers over time. And as you say, if they go up, particularly if the patient has symptoms, that's concerning. And then the CT scan, plus or minus anticoagulation if we find that. And if necessary, a repeat invasive gradient to see what's going on. But I think the algorithm is clinically very useful. So our patients are often managed by multiple physicians, right? So we have our the interventionalists, of course, the general cardiologist, maybe the heart failure specialist, primary care physicians. Patty, do you have any thoughts on how to sort of have these discussions or to educate our colleagues on this phenomenon and sort of how to use this data to clinically follow patients? Because I know that not everyone is familiar with these concepts. What are your thoughts on that?
I think that the concept of a valve team and actually the collaboration of the echocardiographer and the interventional cardiologist in the cath lab has really made communication even better than ever. It's so important, though, not to be subjecting a patient to an unnecessary procedure because of a gradient that is suspected to be too high. So it's really important to communicate with each other. And if you have questions about your echocardiographic study, to communicate with the person who interpreted it and make sure that you understand all features of it. I think Philippe has raised a very important point about visualizing the leaflets. That is absolutely crucial. If you can't do that, transesophageal echo or CT is another approach.
One other thing that we've done in our echo lab is the first echo post-TAVR or SAVR. Whatever we use as the LVOT measurement, we use that same LVOT measurement for future echoes so that we don't have a lot of variability, or at least in that one number. And I think that's been helpful as well.
Yes, it's also good to note where you got the highest velocity. So record that on your report so that you make sure that that is noted for subsequent examiners, if it was right peristernal or subcostal or wherever you got it.
Well, I think we're coming to a close here. So I want to thank my esteemed colleagues here for their time and for their input. I learned a tremendous amount from all three of you. Thank you to Dr. Hermiller, Dr. Pibereau, and Dr. Pellica. So thank you so much for your time, and thanks to the audience for listening. If you'd like to watch the entire video of the initial presentation, there'll be a link presented below. Thank you so much.